We welcome Dr. Muruguvel from Chennai as maxillofacial surgeon from Tamil Nadu Government Dental College. He's an IF teacher and master. He has trained in all-on-4 implants by Dr. Paolo Malo, and then management of TMJ disorders from Dr. Jeffrey Occasion, and welding and conometric concepts from Dr. Marco De Guidi, Italy. He is an active member of European Association of Osseointegration. And we all know, just now I checked, it is about 102 YouTube videos he has uploaded on basal implantology and popularizing basal implantology in our part of country. We welcome Dr. Muruguvel.
Thank you, sir. Good morning, everyone. I'm Dr. Muruguvel from India. My topic is nasal floor cortical engagement and canine bypass technique, two different techniques. First, we will discuss about nasal floor engagement. So the lecture contents are cortical nomenclature, what are the indications, advantages, surgical anatomy, and the techniques and disciplines used, and a little bit about complications. So the basic cortical nomenclature, Dr. Jugal has already discussed. So the nasal floor is the mainly used second cortical in anterior maxilla, which we are commonly using in basal implantology. The indication is it can be engaged in single tooth replacement or for anterior segment teeth replacement, or in full mouth rehabilitation also we can use. So what are the advantages is the C2, the second cortical, is a good quality cortical bone where you can get a high stability, and it is resistant to resorption and favorable force distribution, and immediate loading is possible because of high stability and predictable long-term success of implant, and it is almost present in all situations unlike the alveolar bone. So considering the surgical anatomy, these are the things we should check before starting the case. So the first two things, the buccolingual width and the labial plate thickness, are not very much important to get stability with basal implants. The other things we will discuss. So this anatomical structure is important to see before starting the procedure, nasopalatal canal coming from nose to the palate. And though it is a midline structure, mostly it is closer to the left central incisor. So whenever we are placing implant in the left central incisor, we have to be very careful. So the possible two complications are nerve paresthesia and the failure to osseointegrate may happen. And the shape and sizes vary. And this is one kind of challenging situation where the nasopalatal canal is very wide and huge, and placing implant in this situation may be quite challenging. Here we can see when the nasopalatal canal is present, the usual palatal angulation of the implant we should avoid, otherwise it may impinge on the nasopalatal canal. We have to follow the labial plate. We have to place the implant parallel to the labial plate, unlike the usual situation. And presence of buccal undercuts, this we have to check before. The buccal undercut is mostly commonly present in the lateral incisor region. The depth may vary, mild to severe. And the clinical significance is we may perforate the labial plate during drilling and implant placement. So this is a canine region where there is a buccal undercut. You can see the post-op X-ray, it is close to the undercut. And presence or absence of periapical pathology. If periapical pathology is present, how much the bone has lost due to the periapical cyst or pathologies. So whenever there is periapical pathology is involved, we have to cure it nicely, and we have to place the implant. So here if you see, because of the periapical cyst, the alveolar bone has lost. Only a 3 to 5 mm of nasal floor is present. The BCS is getting engagement from the nasal floor. And this is another case with periapical cyst. After the periapical lesion is removed, we can go through the cyst, we can go through the lesion, and we can get engagement from the nasal floor. And this is a quite challenging situation where there is loss of lot of nasal floor. Only 2 or 3 mm of nasal floor is present. So these things we have to check before